Hi, I'm Alan Moses, the live interactive inventor of Moses Appliances. The present topic is Moses Alpha, our newest intraoral sleep appliance. I am also the Chief Technical Officer for Moses Appliances. The new Moses Alpha challenges a significant amount of current dogma regarding adjustment, dimensionality, and design of oral sleep appliances. I would like you to contact me if you have any questions, suggestions, criticisms, or if there's something in this talk you would like to discuss. Email me to get started at alan@themoses.com, website being www.themoses.com. Introducing our newest intraoral sleep appliance, the Moses Alpha. It's better because it provides optimal oral airway stenting. It supports the oral airway in a stable position. It's possible to establish 5-dimensional positioning. It has a scientific registration technique, very strong and durable. It's ergonomic, meaning that it has excellent biophysiologic design, custom made, and very comfortable. There it is. So let's start updating our thinking on oral sleep appliances. The main criteria for determining clinical effectiveness of an oral sleep appliance: it's got to be comfortable to wear, and it should stent the oral airway to stable, dilated shape, and it should create an acceptable apnea-hypopnea index based on a post-insertion polysomnogram sleep test, home sleep test, or recording pulse oximetry. Oral sleep appliances should be precisely situated in the mouth between the dental arches to achieve optimal oral airway stenting. It is a very complex neurophysiologic position, not easily accomplished, and I might add, not easily understood, not well understood. So here's a picture, throat relative to the mouth. However, that's just an isolated picture. So in our situation, we always have the tongue associated with the throat and mouth. Throat, mouth, and tongue shown here with an intraoral sleep appliance, as you see diagrammed in red. A remote device, the intraoral sleep appliance, a remote device located in the mouth that works with the tongue, nerves, and musculature to stent airway dilation and patency. So here's a picture. On the left is a cone beam rendering of a narrow airway, and on the right, an airway stented open. These two views represent the same airway before and after multidimensional airway stenting, such as can be accomplished with an intraoral sleep appliance. The red is the narrow area, and you see the minimal cross-sectional area. This is the effect oral sleep appliances strive for: airway dilation and stenting, and it's multi-dimensional. Establishing the precise location for an intraoral sleep appliance between the dental arches to create a dilated and stented airway is a very complex neuromuscular problem. The device goes inside the mouth, not in the airway. The airway is downstream from the mouth. The tongue has to fit inside the mouth. Airway stenting is unstable if the mandible is moving. That's why the term stenting is used, because stable positioning is important. Stenting implies stable. The airway is unsupported by ligament, cartilage, or bone. It is both flexible and collapsible, and this is different than in most all other animals. The tongue and human airway muscles have their origin and insertion in muscle. Other muscles have an origin or insertion or both in bone. Human complex design necessitates intricate neural coordination of the oral pharyngeal airway involving, very complex, 5, possibly 6 cranial nerves: trigeminal, vagus, facial, hypoglossal, glossopharyngeal, maybe accessory. Special note here that dental devices in the mouth can stent the airway open during sleep is only a recent serendipitous discovery and still a work in progress. So here we see an oral sleep appliance successfully positioned in the mouth between the dental arches causes stenting and dilation of the oral pharynx, a flexible, collapsible anatomic tube not in the mouth but downstream. Upper left, upper right, you see the Moses Alpha. Lower, you see a different appliance which allows mandibular movement. An intraoral sleep appliance cannot optimally dilate and stent the oral airway when there is mandibular movement changing the airway's shape. Choice of appliance becomes very important. Here we have a picture, many, 8, 10, 12, oral appliances that all allow mandibular movement. The clinician exercises care, skill, and effort to register an optimal, stable, maxillomandibular position for stenting. Mandibular movement reduces that optimal size. Consciously choosing an appliance that enables mandibular movement is both contraindicated and poor clinical judgment. Remember, mandibular movement during sleep changes the shape of the oral pharynx. With all Moses sleep appliances, stable jaw position during sleep is achieved. We have stable oral airway stenting. There are 5 specific dimensions to consider for achieving neurophysiologic facilitation in the maxillomandibular registration of an oral sleep appliance. They are protrusive, sideways, vertical, cant, and slant. One-dimensional, pull-forward jigs that mechanically restrict translatory movement do not replicate biophysiologic movement. Mandibular positioning at 60% of maximum protrusive is arbitrary, unscientific dogma. A study I published in 2012 in Sleep Diagnosis and Therapy, reprints of which are available on the website, showed that condylar asymmetry exists 95% of the time. Virtually all protrusive movement deviates to one side or the other. Moses bite shims can be aligned so the mandible can freely slide into a protrusive position. Jaws do not protrude in a straight sagittal plane. Remember, the average deviation, 5.6 degrees. So, sideways and lateral, another important dimension. It is most important in establishing the sideways dimension that the muscle activity be bilaterally balanced when the patient's in the appliance. Arbitrarily aligning the midline between 8 and 9 over the lower midline between 24 and 25 does not reflect natural human asymmetry or balanced muscle activity. The pegs face up on the shims on the upper teeth, down on the lower teeth. When the shims are against each other and against the teeth properly, the result is smooth sliding to record lateral or sideways. 95% of patients' upper and lower midlines do not coincide exactly. Vertical is a very sensitive component as well to achieve airway dilation. Combining shim sizes can make a difference of a ½ millimeter in vertical dimension. This is important. The blue shims are 2 millimeters thick, the colorless ones are 1.5 millimeters thick. When the correct registration of all dimensions is achieved by a combination of shims, fast set polyvinyl material is extruded between the posterior segments, overlapped on the shims and their grooves for a complete full arch bite registration in one piece. Vertical. As little as a ½ millimeter difference can be significant. Cant. Cant is a combined result of skeletal and muscle imbalance. Cant is based on the finding of frontal asymmetry. You can see on the picture, on the skeletal drawing and the picture on the left, tilt of the eyes in the TMJs and the occlusal plane relative to the eyes. The TMJs must simultaneously move both laterally and protrusively to register the maxillomandibular position for a sleep appliance. Incorporating a cylindrical stick with a cross groove in it in conjunction with the shims, as you see in the pictures on the lower right, allows vertical self-balancing with smooth lateral and protrusive movements. So we can't account for tilt. However, an oral airway dilator does not necessarily correct the skeletal asymmetry of the face. It just balances the neuromuscular activity to a great extent. Slant. The upper right photo shows two sets of identical models. The same combination of shims were used to establish protrusive lateral and vertical in both. Different methods of extruding registration material accounts for the differences in the slant of the mandibular plane angles. The models on the left appear to be masseter dominant person, and on the right temporalis dominant. Being able to factor in slant into registering the optimal treatment position is important for clinicians to understand to achieve optimal airway dilation. So, understanding slant of the mandibular occlusal plane relative to the maxillary can affect the positioning of a sleep appliance in the mouth. The appliance that you make for the models on the right and left will look and feel and be different in terms of airway. Face shapes can differ. Some appear temporalis dominant, others appear masseter dominant. Face shapes can affect treatment decisions. You see the same person's face on the right and the left. The picture on the left appears temporalis dominant. On the right, probably masseter dominant. Do we need to factor slant into our maxillomandibular relationship? Probably. This is not a how-to lecture. The message is that there are better ways to get the treatment position right the first time besides guessing or pseudoscience. Knowing how and when to factor in slant can help. An advanced video on integrating cant and slant into the maxillomandibular registration using manual muscle testing will be available in the near future when we can work on patients and do this without masks in a healthier environment, less contagious environment. The dimensions necessary in registering optimal oral airway dilation and stability and neurophysiologic facilitation for an intraoral sleep appliance are protrusive, sideways, vertical, cant, and slant. Clinicians must know these science to achieve these positions. These dimensions are based on real scientific measurements. Manual muscle testing and bite shims can be used to register all 5 dimensions. Most oral sleep appliances have built-in adjustment mechanisms because The overwhelming majority of oral sleep appliances need adjustment after insertion. Here's a composite picture of what looks like 9 different appliances, all adjustable, and the adjustment mechanisms consisting of screws, tubes, straps, hinges, springs, and rubber bands. That's a big problem. Screws, tubes, straps, hinges, springs, and rubber bands all only adjust in one dimension. They do not replicate biological jaw movement. In nature, human mandibles move multidimensionally and asymmetrically. Oral sleep appliances that are adjustable in only one dimension are obsolete, inadequate, inaccurate, flawed, faulty, and deficient. So you know what I think. Expecting airway dilation on robotic movement in one direction is guesswork. They're not science-based and not even custom. Let's talk about custom. In a custom appliance, all components are specifically fabricated to the unique personal proportions of the individual's anatomy. Screws, tubes, hinges, springs, rubber bands, and straps are not custom, as you can see in all those pictures. Basically, they're store-bought erector set parts, which are not custom. Custom-made shoes, custom-made suits fit better, they look better, and they feel better. Non-custom sleep appliances cost way more. They don't look better, and they don't feel better in the mouth. Now, on the right, you see a totally custom appliance, the Moses Alpha, priced beautifully at $199 to you, and the Alpha Update, should you need it, at $149. Beautiful custom appliances. Moses Alpha and Moses Update. Oral sleep appliances capable of maxillomandibular registration considerate of all 5 dimensions. Protrusive, sideways, vertical, cant and slant, and totally custom made. There it is. It encompasses all 5 dimensions. No mandibular movement during sleep. Stable airway. Once again, there's a picture of the shims. Remember, the 2 blue ones are 2 millimeters thick, colorless ones 1.5 millimeters thick. Moses Bite Shims are the tool for multidimensional registration of maxillomandibular relationship, helping you to get it right the first time. Registering the optimal maxillomandibular relationship is all about finding the optimal homeostatic postural position of the dilated stented oral airway, head balance on the neck and back, balanced healthy jaw relationship, balanced facial neuromusculature, and a tongue position that supports nose breathing. The technique recommended by me for all Moses sleep appliances is manual muscle testing used with the Moses Bite Shims. Here's a picture of me using the Moses Bite Shims in the old days on a patient without mask. Manual muscle testing, MMT, also known as applied kinesiology, AK. A how-to video using Moses Bite Shims and manual muscle testing to register a neurophysiologic maxillomandibular position is available for you on the Moses.com website. It's there for your benefit. I recommend that you use it. Moses Alpha has no built-in adjustment mechanism because our technique for registering maxillomandibular position is so accurate that Moses Alphas usually do not need adjustment. The design is so excellent that Moses Alphas usually do not need adjustment. Moses protocol usually gets it right the first time. But now we introduce a new word, ergonomics, which is integrating the biomechanical elements of the human oropharyngeal system into design and function of intraoral sleep apnea appliances to optimize overall system performance. The Moses Alpha design, comfortable and smooth to the tongue. We're talking design. Increases volume of space for the tongue and the mouth. It dilates the oral airway. Lips can be comfortably closed. It positions the tongue anterior and out of the throat, and the tongue can easily touch the palatal rugae. Palatal rugae, if you think back to oral pathology, year 1 of dental school, Ruffini, Pacini, Meissner, and Merkel end bulbs, which in conjunction with activity from the tongue are capable of stimulating protrusive jaw reflexes. Speech is easily understandable with the Moses Alpha in place. We have an open anterior so you can get the tongue to the lips. Lowers muscle activity in a clench. Facilitates protrusive tongue reflexes, and importantly is that it does not have wrought metal clasps, which we all know cause tooth movement. Ergonomic, the word ergonomic defines the Moses Alpha. So, Moses Alpha at $199 and the Alpha Update at $149. Beautiful appearance, appliance at a beautiful price. The point of this talk has been how and why it is better to just get it right on the first time with excellent positioning and the Moses Alpha. Factoring multidimensionality into registering the proper treatment position is important. Built-in unidirectional adjustment mechanisms have no scientific rationale, and they cost a lot more. In rare Moses Alpha cases you feel an adjustment is needed, it's far more logical and cost-effective to update by registering a new maxillomandibular position, reusing the upper vacuum suck-down retainer, and sending it to Modern for a remake of a whole new lower component at the price of $149. Moses Appliances, not just an unbelievably low price. It's better because optimal oral airway stenting, stable support of the oral airway, 5-dimensional positioning, scientific registration technique, ergonomic design, and it's custom made. It's extremely well made by Modern Dental Lab USA. Laboratory order forms are available on the website, and for a starter kit, if you call for a starter kit to Teresa at Modern, she'll send you a kit of sample shims, and the phone number is 773-631-8888. By the way, going back for a moment, should sleep dentists consider slant or no slant? Yes, but only Moses Alpha can be, quote, updated with the update for slant. Nothing else is going to get you slant. Thank you for your attention. Stay well, stay healthy, and stay in touch.